I invite one of the brilliant and dynamic cardiologists, Dr. Nipun Mahajan, for his lecture on approach towards acute myocardial infarction. Dr. Nipun Mahajan is Director and Chief Interventional Cardiologist at Tagore Hospital and Heart Care Center. He did his DNB in cardiology from Care Institute of Medical Sciences, Hyderabad, and awarded fellowship in American College of Cardiology in 2018. He has been winner of Natesa G. Pendian Award and Young Investigator Award at 16th World Congress of Cardiology and Echocardiography and Allied Imaging, has publications and case presentations in European Society of Cardiology. He's got vast experience in all types of non-invasive and invasive cardiac procedures with special interest in primary angioplasty in acute MI. So over to Dr. Nipun Mahajan.
Good afternoon, everybody. I thank Punjab IMA for giving me this opportunity. Dr. Daya just told me to do it fast. I said, a topic is acute myocardial infarction, sanu cheti treat karna hi penda hai. So now I start with a very basic is how to approach a patient with an MI. Why it is important is that we Indians have 2 to 6 times higher chance of getting an MI 10 years younger than the Western population. A study was done in Berkeley in USA and they came out that we Indians are at a higher risk for heart disease other than even having high cholesterol and being a smoker. Being just an Indian is a higher risk factor. These are a few of the genetic reasons why we get MI early. I'll start with the case example of a male who came with an acute myocardial infarction. His ECG showed an anterior wall myocardial infarction ST elevations in V1 to V6. What happened in this patient? This is the nascent coronary artery. As we grow, there is a plaque which forms. Suddenly one day we get some kind of stress. This plaque bursts. The body thinks that this artery has ruptured. It tries to form a clot to block the artery, and that is when the artery gets blocked and we get an acute myocardial infarction. What decides how big an MI a person will have? Somebody escapes with a small MI, somebody has a big MI. It depends on the area where we get occluded. This is the LAD artery. The artery is occluded here. This much area gets dead. Had the artery got occluded here, this big area would have gotten damaged. The second factor is time. When the artery gets occluded at 0 hours, the whole myocardium is normal. By 2 hours, small amount of myocardium is damaged. By 24 hours, the whole myocardium is damaged. So the level of occlusion of the coronary artery, the length of time, and God-given presence or absence of collateral decides how big an MI we have. These are all the systemic factors which ultimately can lead to death. The diagnosis depends on positivity rate of troponin levels along with ECG levels. The troponin is the most important test which is to be done. It becomes positive at 6 hours. Now we have high sensitivity troponins which become positive even at 2 to 3 hours. So troponin test with a patient has chest pain, ECG is normal, still do a troponin test, a high sensitivity troponin will tell you patient has an MI or not. Our treatment of our goal of therapy is that we have to restore the flow. पौधे ਨੂੰ ਪਾਣੀ नहीं मिलिया जी पौधा सुक रहा है ਉਹਨੂੰ ਸੁੱਕਣ ਤੋਂ ਰੋਕਣ ਤੋਂ ਪਹਿਲੇ ਪਾਣੀ ਦੇਣਾ ਆਪਾਂ we have to expedite the flow to the coronary artery so that the artery we can save. This is the initial treatment we all know. The antiplatelets, aspirin has to be given between clopidogrel, prasugrel and ticagrelor. Any one can be given, heparin and low molecular weight heparin. But what is decisive treatment is that we have to open the artery. Otherwise, this whole myocardium will become dead in 24 hours and there is no point opening the artery afterwards. These are the two options we have, fibrinolytic therapies and percutaneous angioplasty. So thrombolysis is present when there is early presentation less than 2 hours, the vascular access is difficult and lack of access to skilled lab or a delay in invasive therapy. These are the contraindications to thrombolytic therapy: previous stroke, old MI, active bleeding, aortic dissection. These are the drugs. This slide I'll stop for just half a minute. Streptokinase used to be the only treatment which we used to have as thrombolytic therapy. Now we have tenecteplase, retiplase. These provide better opening of the artery, almost 85% compared to 60% by streptokinase. We had a cardiologist with us who used to travel. Whenever he used to travel, he used to keep tenecteplase in the ice pack with him when he used to travel. Ki kadi MI hoya, I will get myself tenecteplase immediately. The best outcomes are by primary PCI. This is to be preferred if a patient comes to a hospital which has a cath lab. a primary PCI is the preferred treatment. The reason is that primary PCI leads to higher rates of patent artery, better flows, lower rate of complications. So any center which has a cath lab, within 90 minutes, a primary angioplasty should be done. It is the better treatment. These are advantages and disadvantages. I will not go into them. This is one slide. I'll again take a little moment. Patient comes to a hospital which does not have a cath lab. What should be your strategy? You have to see all these things, risk of complication, risk of bleeding, and then take a decision whether you want to thrombolize the patient there or shift the patient for primary PCI. The most important factor is if you have a cath lab within which can start a primary PCI in that patient within 120 minutes, then you have to shift the patient, otherwise you thrombolize the patient in your own center. This is an example why primary PCI is better. This patient came with an inferior wall MI with complete heart block in shock with 50 BP. His left coronary arteries were normal. A temporary pacemaker was put to save the patient's life. His right coronary artery was occluded. We opened the right coronary artery and put a stent and got a good flow. What was amazing was after 20 minutes of starting the procedure, this was the ECG of the patient, absolutely normal. Q waves had formed, but ST elevations had gone down and BP was 140/80. And normal heart rate, the sinus rhythm was achieved. If there is a triple vessel disease, patient comes to cath lab, has triple vessel disease, we are doing a primary PCI. The dictum is to open the culprit vessel. Ma'am gave a very good lecture on CABG. CABG has limited role in ST elevation MI, only if there is a failed PCI, coronary anatomy is not amenable to PCI, or there is any mechanical defect like a VSD or a free wall rupture. Post thrombolysis, suppose you have thrombolized the patient. Should that patient undergo angiography or not? The latest approach is a pharmacoinvasive approach that an angiography should be done within first 24 hours as we see that there are still lesions present. These are GP2B inhibitors which are used. I will not go into detail. Second, a lot of times people ask, we had an MI, we had a stent, do we need to take antiplatelets throughout our lives? The latest guideline is that whoever does not have any high bleeding risk, a dual antiplatelet therapy with aspirin and clopidogrel or prasugrel or ticagrelor should be continued beyond 12 months if there is no risk of bleeding. If a patient has already, like I said, पौधा हुन सड़ी गया, 24 घंटे हो गए, हुन की फायदा खोलने दा नाड़ी, उस तो बाद we have to do an angiography and see where the artery is blocked, and then we have to do a viability test to see whether opening that artery is going to help us or not. Managing the ACS in COVID times has been very difficult. We cardiologists had very bad times. Unprecedented challenge, protection for both patient and staff became paramount. Limitations of personnel who could work in cath lab, delay in door to balloon time because we had to get the testing done, led to decrease in primary PCI all over the world and increase in thrombolytic therapy. What has also been surprising is a difficult challenge which we saw. This was a young patient who had COVID with an MI. Look, the patient has no lesion, he just has thrombus within the coronary arteries. So even after doing an angiography, we took this patient for thrombolytic therapy. So the dictum is early diagnosis plus timely revascularization of the coronary artery leads to a healthy heart. And I think I have finished well in time. Thank you so much. Have a very great 2021.